Just a little bit background about myself. I did my residency here, so my face may look a little bit familiar, but I know there's been a lot of changing in staff and changes in the PACU and pre-op. So, and when I walk through, there are some unfamiliar faces as well, but please feel free to say hi. But this lecture, I guess, came about for two things. One is about the artificial urinary sphincter, and then the other one is about Coude catheters. And from what I understand, the Coude catheters, there is a policy that is set forward about potentially not being able to place them as a nurse. And I did try to look at nursing policy, but I don't know if Sarah or Denise, you can comment on if this a policy is a thing or is it more of a discomfort?
I think it's more of a historical thing that in the far past nurses were not allowed to, but it wasn't necessarily policy, and now I think even Dr. Weiser has said that is okay. I don't know that there is or isn't policy. I don't think so, though.
Okay, great. That's good background for me to know, just because I did try to look on the Michigan Medicine website just to see what was available, but I agree with you. I don't know if there really is anything. But this is, I think, one of the first times that we're going through some of this stuff. So, I want to be able to create a PowerPoint for the future where it has some voiceover so that it can be disseminated. And in order to really best do that, I will need some feedback from you all because my perspective is going to be very different from your perspective. There might be things that you were unclear about, and that's totally fine. And I think I just need to know that information just so that I can add that into the presentation so that it makes a little bit more sense. So please, either via email and or directly here, please give me some feedback.
Okay.
And then Sarah, what time should I be shooting for to end by?
We have a really low caseload these days, so we're good for 45 minutes or so. If people
Okay,
have to
so
step
I will
out,
try
they'll
to
just
keep
slide
it
out.
to 30. Okay, I will try to keep it to 30 minutes or less, and then try to have some time for questions and feedback during that time.
Okay, we have
So the
time.
first part is about the Coude catheters. So first thing that I wanted to do was do a poll. Let's see if this will, there we go. The quick poll is general nursing experience, and Sarah, you're gonna have to help me with this.
Sure.
How many people have less than 5 years of experience in nursing?
3 out of
Okay,
20 or so.
5 to 10,
Pardon me?
5 to 10 years.
1, 2, 3, 4, 5.
Okay, and then greater than 10 years.
Everybody else, 1, 2, 3, 4, 5, 6, 7, 8, 9, probably 10.
Okay, so majority have greater than 10 years here. So during that time period, how many people have encountered a difficult Foley catheter placement in a man?
The majority.
Okay, and then how many people have placed the Coude catheter before?
2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13 or 14.
Okay, so a good majority have actually placed one before. So I'm just going to go through a little bit of review and trying to look at some of the data that's out there. I happened to come across this project, which actually is done by a nurse practitioner who is a wife of a urology resident here. They're now in Seattle, but this was done in Detroit Hospital, and it was a quality improvement project to educate nurses on Coude catheter placement. As you may or may not know, the common practice was that if they had a failed catheter attempt, you then contacted urology. And most of the time, they were finding that actually urology did not see that it was a difficult catheter placement. They had some tips and tricks, and then they were able to place one quite easily. But they were finding that this process in general is burdensome to both the providers and the patients. As you know, urology now is in-house call, but before we weren't. And so it would mean that someone was coming in from home, and that would be a time crunch that was happening. And so that became burdensome. They eventually found that after doing sort of these in-services as well as actual direct observation, that nurses felt a lot more comfortable, and it did find that timing-wise it was really helpful. They went into the financial aspect of things, which I don't want to focus on, but they were talking about sort of the cost of a urology consult to the patient versus being able to be able to do it by bedside with the nurse. But that was some of the benefits that they talked about. Now, moving along, I wanted to talk about sort of the male anatomy. And here is an image of a male anatomy that's in the sagittal view. So they've cut somebody in half, and they're looking at it from the side. And so the male urethra is about 20 to 25 centimeters long, So there's a lot more component of it that's on the inside than what people see on the outside. And it starts from the urethral meatus. It has starts from the urethral meatus, and it goes inside the penis. And then underneath here, you see that there's a curve, and then it goes through this area, which this blob is actually the prostate. The prostate is like a donut around the urethra. I think people think that it's just on one side or the other, but it's actually a ring. So if you can see my fingers, this is the prostate around the urethra as it enters into the bladder. The things that I wanted to bring up is that this blue area is actually the pelvic bone. So if you feel sort of above, or the suprapubic region, that's a bone there, that causes this curve that you see down here in that urethra. So if you can imagine that the penis is straightened out, that's how you place the catheter. You straighten the penis, it straightens this part of it, but you still have this curve under the pelvic bone that you have to make. In addition, in young guys or really anxious guys, they can really stop a catheter just by their sphincter activity. And the sphincter is actually right around here. I don't know if you can see my mouse moving, but that's really where your urethral sphincter, or one of them, is. And so they could really clench down, and then they could block your catheter from coming in. And then another thing in men is their prostate. So, you know, right now this looks like a really nice open pathway to the bladder, so it should go in really nicely. But that's not always the case, which you'll see in the next slide. So BPH, that stands for benign prostatic hypertrophy. And, you know, with the benign prostatic hypertrophy, you see that this is a normal prostate. And the urethra is quite open, so there's a nice open pathway. I can see that in a lot of young men, like 20-year-old, 30-year-old. I have a really open pathway to be able to get into the bladder when I'm doing a scope through their urethra. But as BPH develops, it grows in very different ways. So when people say they have BPH, it doesn't always necessarily mean that they have a big prostate. It just means it's growing maybe into the urethra, or it can grow into the bladder. But, you know, it can be quite lobulated, irregular, and you can see that as your catheter is going through, it may hit that resistance there, and that is causing sort of a blockage. And not to mention, like I said, that sphincter is right there, so that might be something that's blocking it. And right now, I'm just going to stop sharing for 1 second because I promised that I would record this, and then I did not press the button. So,
recording has started.
Perfect. So I'll go back to sharing the screen. Great. So moving along, you have different types of tips on the catheter. And you may have noticed it, you may not have noticed it, but this is your standard catheter, straight tip. They have the holes, there's 2 or 3 holes at the end. And the difference is this curved tip. Okay, so it just curves upward. And that would really help make that turn underneath the pelvic bone to go into the prostate. The other difference is that right here, it tends to be a little bit stiffer at that tip. So it's able to not buckle when it gets there. So the whole Foley catheter is pretty flimsy. You can sort of bend it. I have a catheter here with me. It sort of bends, you know, it's not going to be stiff. And so when it hits a resistance, it wants to buckle. And that's generally the thing. But this tip here, it has a curve at the end, and it has a stiffer end that will make that curve helpful, especially if you have the penis that is straight and it's taut. There's different types of Coude tip. I don't expect people to, I don't think our residents even know that there's differences, but they notice just from experience the different types of tip and the way they look. So olive tips, I happen to see them more so in your sort of stiff intermittent catheter tips. It's a shorter sort of curve that you're seeing here, and it's less of a tapering, and there is a more obvious ball at the tip. But I do like these because they offer some resistance. They're a little bit more stiff, and you know, they offer that curvature that I need. The Tiemann tip, you usually see that with more of your latex catheters. So I think I have one right here. This is a 16 French Tiemann tip. It's a lot more tapered length, and it also still has that little bit of a ball here to give you that extra stiffness there. And then the standard Coude tip, I see these more in your other silicone catheters. Now, the thing that I wanted to talk about before I move on to the next one is that the upward curvature is what's really helpful, right? So once it's inside the body, you ask yourself, how do I know that that tip is pointing upward towards the sky? Because that's what's going to help you. If it's to the left, if it's downward, it's going to make that same buckling in that area, and you don't want that to happen. So what's nice is that all of these catheters have a marker. And on like a latex catheter, wherever your balloon port is, that's going to tell you that your tip is up. And I'll demonstrate. So this is where the balloon port is up, and so is my tip. That's up. If this were down, my tip is pointing down. So that's how you'll know, and you just have to keep an eye on that, especially when you're going into that resistance.
Yooni?
The other thing, yes.
We have the slide up with the 3 different types, but if you're showing us something, we can't see that. If you were showing us the catheter with the balloon.
Show my video. Yes. How is it now?
1 second.
You can see.
Yeah, now we see you.
Okay, sorry. So this is a T-Man sort of latex Foley catheter. You can see that the tip is up, and then I'll sort of follow it all the way, and the balloon port is up. Mm-hmm. If the balloon port is down, the tip is down.
Got it.
So that's the way you know when obviously this goes inside the body, you're like, oh, I don't know if the tip is up or not. You just definitely look at this and you know that the tip is up. So that is what's going to be helpful. If you hit this sort of area like this, it will just buckle. It won't make that curve that needs to go up. Were you guys able to see that?
Yeah.
Great. Okay. So kind of going back to this, the question, I think some people may have experienced this. They've experienced it when they've had a difficult catheter and urology comes in and it goes in like, easy peasy. People have had experiences of where, they've tried, they've come across hematuria, but then, urology came in and they also were not able to place it. So what is it that I think about when I've seen a failed catheterization? So one thing that I can think about is, do they have known BPH, any prostate issues? And easy ways to do that is see if they're on Flomax or finasteride. That's a common way. The other thing, sometimes I ask them from a urinary standpoint, do you find that you have a very decreased stream or that you wake up at night a lot? And sometimes they'll say, I pee just fine, but I wake up 4 times a night. And sometimes that's a clue into maybe they have some BPH. The other thing is, do they have a possible stricture? So that's another reason why it'd be a difficult Foley catheter. That's a little bit more difficult to sort of elucidate from either the patient's chart or the patient history. But things that you can ask is, do they have a history of a stricture? Because then that can help you figure out what the next step is. And oftentimes when urology residents are kind of coming along, what do they bring with them? They'll oftentimes try to bring a Coude catheter, and they'll also try to bring maybe a smaller catheter. So those are some of the things that they are arming themselves with when they first come, and that usually it works maybe 80-85% of the time. And so when they have known BPH, I like to use a Coude catheter because it will make that curve that happens to be able to make it and around that curvature behind the pelvic bone, but also to have that stiffer end so that it can pass through the lobes of the prostate. And people are like, well, intuitively you want to put in a smaller catheter, but actually a bigger one gives you some more stiffness. And so my favorite one that I would take around with me is usually an 18 French Coude catheter or a 20 French Coude catheter, and that usually went in with ease. If you're thinking that they might have a possible stricture, or maybe something happened where there's a false passage, sometimes a smaller catheter helps. And I like the silicone because it does offer more of the stiffness than maybe a latex catheter, because the 12 French or 14 French latex catheter will oftentimes just buckle around that area. So some of the pearls that I would say is that from a Coude tip standpoint, there really is no significant difference except for the curved angle and the stiffer tip. And so you just need to make sure that when you are placing it, that you have the balloon port or the marker on the catheter pointing upwards. And every catheter's marker is a little bit different, but you'll see either a bump, a black mark, or the balloon port. And then size still matters in just the sense that, a bigger catheter will help you with the stiffness of the catheter to be able to get past the prostate. And then, smaller catheter, that's what's needed in a stricture. It doesn't matter what curve tip you have, it still will get through that strictured area. And then as a side note, this is something that I talked to the residents and our APPs about to see if they had any other feedback that I can give to you all. And one thing that they come across, and this is mainly on the floor, but people will meet some resistance when they're pulling out a silicone catheter. But that's because of the balloon port on the silicone catheter creates a ridge, and that's the resistance that you're feeling. So sometimes what I will do is maybe inflate, deflate, and inflate the balloon inside the bladder so that it softens that up and may kind of sort of relax the balloon in a different form. And the other thing is a gentle tug. I know that sounds really uncomfortable, but that may be the only way to get that catheter out. There are other ways, but one way that we have utilized in the past is to try to essentially pop the balloon by overinflating. The reason why I don't like that is because then you have sort of foreign body inside the bladder that you have to go after later. So I think this is a good time to stop and ask for questions about the Coude tip. What can I answer for you guys?
I don't think anything about the catheter itself right now.
Okay. What about catheter placements with the Coude catheter?
What were you talking about with false passage, or are you going to talk more about that?
No, actually, that's a great question. This is actually the end of like the Coude catheters and Foley catheters. So a false passage essentially is that when you are passing the catheter and it meets resistance and you sort of press and then you kind of pull back and there's some blood there, it's because along that tube you've essentially created a divot in that. So essentially it should be a tunnel all the way through nicely, and you were able to pass something through and the mucosa is intact. But in the case of a false passage, that catheter created a divot either downward, left, or upward. Usually it's down, where it dug into that area, created a mucosal tear there. And what ends up happening is in future catheter placements, it wants to go into that divot as opposed to following the path of the urethra. So that's usually what a false passage is. And so we really note that when we are, let's say the difficult catheter requires us to scope the urethra, we can see that downward, that there was a divot that was created, and then we just go upward because that's usually where the urethra will be.
Okay. Any other questions? Coude questions?
So it never heals? The divot will never heal once it's made?
So it will heal. It just oftentimes, that's why we leave the catheter after seeing a false passage, because that will heal around that area. After a false passage, they can be at high risk for creating a urethral stricture, which is a narrowing in the urethra, but that's not always the case. And usually with a catheter placement of about 3 to 7 days, it will heal over that area and can stay open.
Okay, good. I also was taught a long time ago to, I saw somebody, not here, cut the tail of the balloon and let the water leak out. And I was taught to never cut, to always aspirate, because there was a risk of the balloon not completely deflating.
So most of the time I will deflate, and cutting the balloon is also perfectly reasonable. So I think both options are fine.
Okay.
The thing that we were always taught was when you are deflating the balloon, that you really want to pull back all the way, and even to the point where you're getting back air or nothing, to have that negative suction in place, just so that you know you have fully emptied. And I have not seen it where it's not emptied in that note. If it's not drawing back fluid, you obviously think that there's something might be wrong, and sometimes overinflating just a little bit helps sort of release that valve and mechanism and might help. The reason why we were taught always to pull back until you really get nothing, so even more than the 10 cc's, I'll empty the 10 cc's and then do it again, is because oftentimes in urology too, we may put more than 10 cc's in the balloon, and so we are always cognizant of it, and we just we just kind of rather assume everyone else might be doing that rather than pulling it out when the balloon is semi-inflated.
Thank you.
Anything else? All right,
Anything else?
One more question. With
Yeah.
you said the younger patients and the sphincter tone, like what kind of tips do you have to help them? I mean, anything besides just tell them to relax and take deep breaths and all that?
So those are both utilized very regularly, especially while I'm doing cystoscopies. Other things that we utilize, and I'm not sure what nursing policy is on this, but Lidojet will help relax them, even knowing that they have a numbing medication, even though to me it's really just at the tip, it doesn't even touch the sphincter. It may help them. And we put that directly into the urethra just so that it's opening up the urethra along that length. Other things that I have found really helpful, and it sounds weird, but it's wiggling your toes while they're doing that breathing exercise, having them using those muscle contractions down there as opposed to focusing on their pelvic floor, I think has been helpful. Other than that, it's just kind of like going as fast as you can sometimes without them really knowing, because a lot of this is in their head, and then they just sort of are, clenched down from the start. I can see their face, it's turning red, turning blue, and I just say, you've got to breathe through it, and then I'll say I'm relaxing. We won't really get started, and then by that time I've placed it and they didn't even know.
Okay. All right. Oh, one more question.
Yes.
We have a patient that have a straight cat.
Do you want to come up, Karen? Because it might be hard for her to hear you. Just come up.
So if the patient needs to be straight cat and I can't, he has a history of BPH, then I can't have the urine come out. It has resistance. The patient actually asked me to get a Coude cat. Do we need an order from you, from urology, or just anesthesia?
I'm just going to repeat the question. I don't know if I heard it correct, but if the patient has BPH, they need to be straight cath,
Yeah.
and a Coude catheter is requested. Does it require an order from urology?
Yeah.
Is that the question?
Yeah. Yes.
So if a patient has to be catheterized, do we need an order to use a Coude, or can we just choose to use it based on what we know about the patient?
From what I understand, there is no policy for Coude catheter use or not. In urology patients, you're not wrong in sort of clarifying that always. But in a general patient population, I don't think that you need a separate order because you are just trying to get them catheterized. And, from a nursing perspective in our clinic, all our nurses do that. They make the decision. The only time they need an order from us is if I need to order specifically for home catheter use, whether it's a Coude or not. And that's because companies have us prove to them that they need to use a Coude catheter. But otherwise, they will try different things. Same thing in our algorithm where you try standard catheter. If that's really difficult, then we end up using Coude catheters and they make that decision.
Okay, thank you. Anything else?
Yeah.
All right, I think that's it. All the questions for now.
Great. So we're going to move on to doing the AUS. So let's move on here. All right, so the AUS is the artificial urinary sphincter. I'm not quite sure how often you all get exposed to this, but I mean, obviously we do the artificial urinary sphincter surgery, so I think it's helpful from a postoperative standpoint, but also there is the rare patient that you see in pre-op and PACU that have a history of this and what that means and what it is that we are looking out for and when to call urology. So what is an artificial urinary sphincter? It's placed in people who have stress incontinence. Historically, it has been placed in women, but that is really not the case anymore. It's mainly in men, given their urethral length and the ability to place this device in them. It's a 3-piece device. As you can see there, it's a cuff, a pump in the scrotum, and a balloon that's either next to the bladder and or in your abdominal wall. It's not drawn to scale. It's quite a small balloon, and I'll show you guys in a second because I have a sample here. But it's a pressurized balloon. So from a surgery standpoint, since this is a foreign device, we have them undergo preoperative antibiotics, and we're, I think, pretty stringent about sort of what we need inside the system, and we really want them called in into pre-op early to get the vancomycin and gentamicin started. And sometimes we also add fluconazole. That's a new one that's been added, especially with the high prevalence of patients with obesity and diabetes. The incision sites, you have one that's below the scrotum, so that's our perineal incision. You also have one in the lower abdomen, either on the left, right, or in the middle. Most of the time, the faculty here, we usually choose either left or right, and it's highly dependent on where you place the pump and sort of what dominant hand the patient has. Now, from a postoperative care, we expect that they're going to leak urine even afterwards, and that's because the device is not activated. And so they should continually be leaking, and so they will likely need a Depends or sort of some pad that they are able to go home with in recovery and or up to their patient room. The other thing is that we recommend that they pull down on the pump. That's really to minimize scarring and to make sure that it doesn't ride up, because that pump is essential for them to be able to use it in the future. And if they have really no access to it, it's not going to be a great device for them. And we oftentimes will follow up with them in 2 weeks for a wound check, and then they get to activate this device in about 6 weeks. So